Hi there, Dr. Terry Schoenfeld for UAB Department of Medicine. In this video, I'm going to review some data to try to answer the question of who needs preoperative pulmonary testing. And I'm going to focus on PFTs and chest x-ray. And I'm going to focus on patients undergoing non-cardiothoracic surgery. Patients undergoing thoracic surgery or cardiac surgery should really be evaluated by pulmonologists to determine their risk and the role of testing prior to those surgeries. So who needs preoperative pulmonary testing? Well, almost no one. And the American College of Physicians recommends that preoperative spirometry and chest x-ray should not be routinely used in predicting risk of postoperative pulmonary complications. And the bottom line reason is that almost everything that you could detect by PFTs or chest x-ray will probably be known after you do a history and physical examination. And there's little utility for adding on these tests, and they're just add to the expense with no great clinical impact. So what about pulmonary function testing? Well, it's not overly useful, but the data is very limited. There's several studies in this area, but many of them are small and uncontrolled. And this one I have here by Warner and colleagues, published in 1999 in Anesthesiology, is one of the better studies. And what they did is they took patients they labeled as having airway obstruction. These patients had pretty significant airway obstruction because their FEV1s were less than 40% of predicted. And they compared them to a group of people who had no airway obstruction. And one of the nice things they did is they matched both of these groups on gender, surgical site, smoking history, and age. So they tried to control for important confounders in this study. And they looked for postoperative pulmonary complications up to 30 days after surgery. And the only thing they found was that bronchospasm was the only thing significantly associated with having a low FEV1 on preoperative pulmonary testing. Now, some of the other things like prolonged intubation and pneumonia were increased in the group that had airway obstruction, but it was small numbers, so they weren't able to show any significant association between PFT results and postoperative complications. Now, there are some other studies that have very mixed results, some showing a strong association, others showing weak or no association. It'd be nice if there was a meta-analysis putting all this together to give a nice overview answer, but it's not going to happen. There's too many studies that have too much heterogeneity to combine together. So I think this gives an overall representation of the data. Well, chest x-rays often show abnormalities, but it rarely changes management. So this is a systematic review by Archer and colleagues, and they reviewed 21 studies, and they're pretty mixed. Some are prospective, some are retrospective, as you can see under study design. And what they found was that about 10% of the time a chest x-ray had an abnormality on it. But importantly, most of these were expected, and only 1.3% of the time was there an unsuspected abnormality seen on chest x-ray. And rarely did this influence management. So even though we saw abnormalities, it didn't really add to more testing or change the surgical approach. Now, there's some other studies, and another review by Smetana and colleagues showed something very similar. It was a little bit more recent, published in 2003 in Medical Clinics of North America. And what they found was that 23% of patients who had preoperative chest x-rays had some abnormality on chest x-ray, but only 3% of the time did it influence management. So a similar theme here, that we can see things on chest x-ray, but it really doesn't impact what we do, whether it be further testing or changing the operative course or the perioperative management. So in summary, preoperative PFT should be limited to patients in whom we really don't know if their COPD is optimally controlled or not, or even if they have COPD based on our clinical evaluation. If patients had unexplained dyspnea after a history and physical, we should probably get pulmonary function tests. But the thing to remember is studies have not really shown a basement, if you will, of FEV1 level that precludes surgery. There's been some observational studies with patients that have pretty low FEV1s, and they seem to do fine with surgery. So I can't tell you if you do PFTs that what you find on them will preclude surgery. Well, what about chest x-ray? Chest x-ray rarely influences management, and we really ought to limit chest x-rays to patients who have known cardiopulmonary disease, but probably more importantly in patients over 50 who are undergoing high-risk surgeries. But then again, you might find something, and I'm not sure it's going to overall influence your management strategy, or further testing that you do in these patients. And probably you're going to detect all the high-risk patients anyway, clinically through your history and physical examination, and you're going to do interventions to try to lower their risk. So I'm not sure, even though it's recommended or suggested that this is a group of patients who should undergo these tests, that it's overall going to influence what we do.